Everyone to another grand rounds. If I could have everyone's attention. I'm going to do a quick introduction for Dr. Erdmann. Dr. Erdmann's one of our own here from UAB, from the Division of Infectious Diseases. Originally went to medical school in Nebraska and did a combined MD Ph.D. program there. His Ph.D. was in experimental neuroscience. Came to UAB after that for residency and did another combined program for residency, fellowship, and then also a research component to that. Started in that division in 2015, has been here since then, became associate professor in 2022, and then became medical director of the 1917 clinic in 2023. We've had a lot of good presentations from people associated with 1917 clinic over the years. Oh yeah. Yeah, we've had. Perfect. Okay. Recent honors include being one of the AMC 21 featured discovery recipients. Also getting one of the Dean's Excellent Awards and Service that's just in the past few years. As far as his research goes, much of it's focused on understanding immune responses in chronic viral infections. It was particularly useful in the COVID-19 pandemic, where he was part of a group that initially characterized immune activation in acute COVID infection, but then some of that research expanded to understanding long COVID. And it's partly because of his work here at UAB that UAB is one of the institutions that participates in the NIH recovery long COVID study. Got a lot of active grant support, including from the National Institute of Allergy and Infectious Disease. So it's really good to have Dr. Erdmann here today talking, and he'll be talking on the path to understanding long COVID.
All right, good to see some familiar faces. Thanks for coming. I have a bunch of slides, but I'm happy to talk about whatever happens to come up. So we can field whatever questions. When I was kind of laying this out, I thought about doing kind of this like big, broad review of long COVID, but then thought you'd get bored of a literature review. So then I thought about doing very kind of data-driven, but then definitely thought you'd get bored after looking at our flow cytometry. So I kind of did a hybrid where talking about some of the stuff that we started and then how that evolved with the field into what we do know about long COVID. Looking at the title when I was sitting there, it's like, this kind of suggests that we got this all sorted out, and that is not the case. We do know a heck of a lot more now than we did a couple of years ago about what kind of happens after the acute phase of illness. So that's what I was going to try to kind of get at. But again, I'm game for whatever. So if there's questions, raise your hand and we'll dig into it. All right, so just as a brief introduction, I remember I read about a febrile illness in China over Christmas week because I was reading kind of the global logs of infectious disease outbreaks. And there was an association with the market that happened very early. And then there were the cases that started coming out in Wuhan. And if you actually pay attention to those things, this happens like once, twice, 3 times a year. Like this is a very frequent thing that, oh, there's a febrile illness going through India or Southeast Asia or whatever. And this one was kind of that regular blip on the radar. And then this showed up in Iran, which was peculiar, and especially once it started being the same thing. And then once it showed up in Italy, it's like, oh, I remember calling my dad, it's like, everyone in the world's going to get this. He's like, ha. I'm like, seriously. And then, so it was right in early to mid-February where we started kind of thinking about how it's going to play out. I'm sorry. And what are our questions and what is our role going to be in this? And typical to other infectious diseases, the mortality rate looks completely overwhelming on the front end because there's such availability bias, but trying to think through what is this going to look like and how is it going to play out? This is just to kind of remind, and Sixto is not here, but I should have like put in some arrows of what Sixto was doing at the same time because we were involved in a lot of the same meetings. But we had this kind of initial announcement. We started talking about, well, actually, so I'm not talking about some of the clinical trials and interventions we did, but the ACT study, which was the big NIAID directive for looking at a multi-platform study, their first enrollment was February 21st. So that happened right about here. So the NIH was already gearing up at that point. We started talking with them right around that same time. Our very first case, which because Sixto was too slow, was probably not our first case. But the first one we actually had a positive diagnosis was here in early March. And I actually have those samples in the freezer. So the very first time we had a patient that come in, we had a protocol up and running. So we processed that sample. We were in parallel running an outpatient platform where people that came in with probable or confirmed COVID were coming into the outpatient. And then we were getting early convalescent samples and started following them out. Our inpatients, we followed them as much as they were willing and wanted to be followed. Our outpatients kind of had already self-selected for being motivated, so we started kind of watching them regularly. And pretty early on, we started doing some survey work to capture patient-reported outcomes, and then that started formalizing more from there. So this is just a brief summary of what this looked like. We were doing this ad hoc, and then because of the limitations of getting into the hospital and using PPE, there was an institutional interest in consolidating these efforts. So yay me, ended up the one who was chasing around everywhere trying to get patients early on, and then we ended up building kind of a research infrastructure for this. On the outpatient side, we enrolled about just shy of 200 people in the end. I ended up getting, it's right around actually closer to 6,000 people that we enrolled with acute COVID. Many of them we got samples on. The way I ran this, and we still talk about this way, is there was a sushi menu for an enrollment. So like you just kind of check all the boxes. So we end up working with the IRB, and the IRB was very extensive, but if we would just kind of knock on your door, you could do verbal approval, like, hey, would you be willing if we followed your data through your COVID disease? And if they said yes, we would just kind of acknowledge that and then enroll them. And then we'd ask them, would you be willing to give samples? And if you'd be willing to give samples, then okay, we'll capture that. What about everything else? So I ran around for 6-0 and we were catching little shooters of saline. We were collecting stool samples, people that got intubated, we were capturing bronchs and everything in between. And so we have PBMCs now on pretty much 2,000 people from the acute side. And then we have a whole bunch of other samples. We published multiple papers on manifestations from the renal collection system. We found endothelial cells productively infected with COVID that was shedding in the urine, which really got my attention. We started thinking about renal transplant patients. We published multiple papers on bronchs, and we have a whole grant, and I'll talk a little bit about on doing bronchoscopy. And then I'm going to tell you some of the story about what we were doing with those immune cells in the lab. There are a lot of people that did this. I ended up being kind of the very pointy end of the spear, but there were a whole bunch of people kind of helping facilitate this and making this work at a systemic level. And here's a lot of people that did even more work than I did for it. This is, again, just kind of a summary for it, and another way for me to give a hard time to Sixto, because we were both kind of living and sleeping here through much of that. But we onboarded the clinical trial such that I didn't put the date on here, but we started enrolling in March, maybe the first week of April for ACT. And then that study actually closed while we still had people on study, and we unblinded and then gave them remdesivir because of this study was actually stopped slightly early, which ironically is the reason almost certainly that it's not considered a mortality drug, because we just came up a few short on the power analysis. So the subgroups hit mortality, but the primary analysis didn't. So now we say it shortens hospitalization, but doesn't cause mortality benefit, which led to like 3-4 years of fighting between the NIAID and WHO. All right, so we're running all over the place collecting these samples. You may recall things were a little weird at that time. So we had multiple labs that had some expertise, but weren't really running other projects right now. And so I was going through and literally getting the blood on the floor, then bringing it back, and then going back to the hospital and enrolling someone in clinical trial. But then we were processing these samples and running stuff real time. And the very descriptive, superficial question was, what the hell is going on, particularly for these sick people? The more nuanced question, which I'm not going to spend a whole lot of time on, is we were trying to differentiate. I would go up to the floor, especially when things were bad early. I remember going up on M9, which was our first COVID ward, and you'd have the whole floor. Everyone would have their yellow bags and then their garbage bags, PPE lining them. And everyone on the floor would be on 2 to 4 liters of oxygen. And if you sat on the floor for more than an hour, which I did all the time because I was doing all documentation and enrolling people, one of those rooms would get a Met call. And then they would immediately get intubated because we were trying to do secure airway because we didn't want to have people shedding lots of virus. So they would get intubated quickly. As soon as they started decompensating, we would intubate. But I was as much of an expert as anyone in the world at that point, and none of us could tell who the hell was going to be the person that would get worse versus who were the people that were going to get better. And so that was really the basis of what's going on early, and can we start getting at what changes or what's declaring those people that are preparing to decompensate versus those that are going to go from 2-3 liters today to back on room air the next day and going home. And sincerely, we really couldn't tell. I'm a little bit better at it now, but it's still very clinically diffuse as far as what that really looks like. So we took a whole bunch of PBMCs and then tried to look at a bunch of things. My background is more of an HIV T cell guy, and we kind of leveraged those populations and interests, but looked a little bit more broadly too. And just looking early on as far as those that were pre the existence of SARS-CoV-2 versus those that went in the hospital versus those that didn't go in the hospital, kind of leveraging the different cohorts we had, and start looking, are there big sweeping changes? And as far as cell distribution, not so much. We started looking at some of the activation markers that we think about, particularly from the HIV perspective, which I'll touch on a little bit later in this. We found evidence that there's clearly stuff that was going on with the immune system, which is, again, not tremendously shocking. But these are different markers of ways of looking at, these are T cells here, how activated they are. And it's interesting to see just how different it is for the hospitalized patients versus the non-hospitalized patients. There's all sorts of background data and tables to show that the timing is relatively comparable and all the other stuff to this. I didn't want to bore you with that, but if you're really bored, you can get the paper. And then even if we stratify those that are in the hospital, you can see this group here on the no ICU looks a lot more like the non-hospitalized than those that were tipping over and getting intubated and having respiratory collapse. It really kind of speaks to how much activation is going on. And one of the key takeaways from COVID in particular is that it's less the overwhelming virulence of the virus and it's so much the immune pathology that's delivered in rapidly progressing severe disease. And we can find evidence of that in different ways. So this is that same, these are the same data just split apart by whether or not they end up transitioning into the ICU. Good news about these cohorts is that they're pretty clean for normal-ish people that then got COVID. As we get farther out, it's more and more and more skewed to hosts or subgroups that are either not getting vaccinated and or have comorbidities that sets them up for additional problems. But we can still find them. I admitted one of my other clinical study patients with acute COVID, and he ended up decompensating on high flow. So it's still happening pretty regularly. This actually wasn't the story we thought we were reporting, but this is actually how this work ended up in JCI and what the takeaway from the study was, because I'm not showing it all here, but there are approximately 9,000 papers that show a lot of this that all happened in 2020 into 2021, because again, no one else was running labs. And so we were, again, on the front end of things, but there's a whole lot of people doing fancy ways of looking at inflammation. But we were probably the first to really show that here's what happened early on with acute COVID. And then once things clinically look better, the immune system doesn't just go right back to normal. And that was kind of the takeaway of this disease presentation. And it was actually even more apparent in those that weren't severely ill. It's that those that had relatively typical infection would have this kind of ongoing immune activation that wouldn't immediately settle back into baseline. And this was not unique to one random marker. It was a trend that was clearly present. So this was of interest. These data were gathered in 2020, and the paper was accepted in the fall, although it didn't actually make it into press until right in January 21. But this was before long COVID was an entity that was recognized. Right about the time we were writing this paper, we actually had developed a cohort of what looked to be 6 people that had bona fide COVID reinfection, which you may not recall, but the CDC was literally saying that is not something that's possible. So we were having calls with the CDC, and we had this paper that was sitting at New England Journal when the Taiwan case was diagnosed as the first person that had genetically proven reinfection. Still a little butthurt about that because we had this like diverse cohort of 6 different people that were reinfected, but the paper just died completely and never found a home after that first publication of a single patient was reported. It was all the healthcare workers that got infected early in March and that we were following them. And every time they would get symptomatic, they would call ID and we would counsel them. And so there was these cases that started popping up that were very clearly acting like COVID, but they couldn't be COVID because they'd already been infected. But as we all know way too well now, I have kids, so I think I'm on COVID number 4 or 5 right now. Seeing thousands of people in the hospital, never got it in the hospital, despite being in the worst rooms you could imagine for people that must have been shedding amazing amounts, but it's damn kids. So this is another way of kind of looking at the time after initial presentation and what's happening with this immune activation and some of the transcription regulation of T cell function that just didn't really want to go to baseline. So this is another really boring piece of data in retrospect showing that once you get COVID, you mount an immune response and then you have a memory response. That's how it's supposed to work. This is some of our data that got published. This is another nice paper that made into a better journal because that's how the world works. But showing that this is kind of the frequency of what's happening. But we had these data now that we'd published showing that things didn't resolve but you could see that it wasn't uniform on those bars. And so and then this is right about the time that long COVID was being whispered, although it wasn't broadly recognized. Like, I wonder if it's not just immune activation that's going on the whole time. And so we really thought what was happening is that we're going to find these markers and they're going to be up, and that may be what's actually driving these symptoms. And if you start thinking about some of the symptoms of long COVID, there's very good overlap with kind of having flu-like persistent immune activation. I'm going to cut to the chase early. Nope, nothing. Systemically, here's this same observation that we had in the kind of peri-acute phase. So this is around day 30 or so. By the time we get to day 60 and day 120, I think, it's completely gone. So there's no systemic signal. Obviously, there's people that are a little higher than other people that are a little bit lower, but that isn't what we thought we were going to see. We were expecting to see subgroups that would start popping and lingering or maybe fluctuating, but it was a very, very consistent trend. One caveat to this paper, because there are other papers that have come out that have shown a different observation than what we did. We happen to catch the magic window period of people getting COVID through early 2020 into early 2021, but they weren't generally getting reinfected and they weren't generally getting vaccinated. So most of the people we had one encounter with spike, whether it was vaccinating or infection, and they weren't getting reinfected. Because what we found later was that when we started looking at immune-specific responses, so not just looking at systemic inflammation, but immune-specific responses, is that typically we would see this trend here of a persistence in the immune-specific response. So we show that the immune activation goes down, but the frequency and magnitude of immune or antigen-specific responses to SARS-CoV-2 persists. So we looked at this in a couple different ways. This is CD4 T cell populations. This is TFH populations. And then we looked at it in antibody, and this is acting like the immune system is still responding to SARS-CoV-2. And remember, this is biased for those that do and don't have persistent symptoms. This is before long COVID was defined. We defined it as at least 2 symptoms that did not include ear, nose, and throat really changes in smell, because that was so prevalent. We didn't know if that was really going to qualify for long COVID. So there's this difference in the red and blue of those that recovered versus those that didn't. Again, so now there are other reports, again, making it in fancier journals generally, that show that this doesn't happen. But when you look at their cohorts, there are people that are getting reinfected over and over. This washes out very quickly if you get re-exposed to the antigen. We were very delicate in saying, after comments from our reviewers, that this is acting like a reservoir and acting like persistent antigenemia, but they got really upset with us suggesting that it was evidence for that, but it certainly acted like it. And that was one of the questions here, is like, at least for some of these people who have symptoms, why is the immune system persisting on it? Is it because it's not down regulating appropriately? But again, the systemic activation was going down, or is there some persistence of the virus, whether that's replicating virus or whether it's just leftover antigen? What we did know for certain at this time is that I would have people that would get hospitalized, they would get ill, and then a lot of them would get better. But for a good chunk of time, the first place this was apparent is that people needed to go back to their nursing homes, and the nursing homes, not unreasonably, would insist on them being COVID negative. And in some people, that was very straightforward. They would be sick, they would be on oxygen, they would not be on oxygen, they'd be approaching baseline, we would swab them, they'd be COVID negative, off they go. There would be some that would say COVID positive, and then they would stay COVID positive, and then they'd stay COVID positive, and then they'd be like camping out on S8 or wherever they happen to be, and it'd be 6 weeks later. They were desperate to be getting back to their bingo, and the hospital was desperate to be getting them out of here, and yet there was not a place to put them, and they kept remaining positive. Obviously, it makes sense that those that had more severe illness, particularly respiratory failure, were far more likely to have that. And not surprisingly, as we started looking more and more for it, those that were immune suppressed certainly had greater abundance of this. But what was interesting is that if we would do bronchs on these people or we'd take it back to the lab, very rarely could we culture the virus. So it looked like accumulation of lots of nucleic acid that had been left behind from these kind of overwhelming infections. But again, when you start layering that against these data, is it all just debris, or is there something that's persisting? And that is what we did not know. All right, I'm going to take a transition and then kind of make it back to this. So as that paper kind of moved out, long COVID started being a thing that maybe wasn't broadly recognized, but certainly was a phenomenon that was being discussed. it's kind of enormous to think about what this disease is. I haven't seen great data in the last year to 18 months or so, but there was some data not too long ago that was making the case very convincingly that at that time, essentially 10% of all walking, talking Americans were dealing with long COVID. The burden of that long COVID has a wide variance. So some people are literally bedbound, whereas some people do fine, but they used to run marathons, and now after mile 2, their chest just tightens up in a way that it didn't used to. But obviously they're highly functional, but there's clearly something different. But 10% of all people experiencing it. This has pretty profound impacts when the prevalence is that high. So this is just looking, this is a nice study that, and then I know Hannah pretty well now through a variety of different meetings where they did a big sampling of this cohort to show how impactful this was on the ability to work. And there's a bunch of different ways to look at this, and we've done some of this type of work as well, but this is a nice paper. And this is another way of kind of breaking down and simplifying how this works. So you can have people that have symptoms that they can discreetly point to, but they're doing fine. You can have some that just can't quite do everything, but they're getting by. And then there's others that, again, their world as they know it doesn't work the same way. And some of those people were frail and had heart failure, but a lot of them were not. And some of them had pretty mild infections, and now they're profoundly debilitated. And then they come to see someone like me, and we really don't have much of anything to offer because we don't even know what's going on yet. One thing that I think is enormously underappreciated when talking about long COVID is that this is not a new thing. It is new to COVID because it literally didn't exist. But the idea of post-flu not recovering to baseline is not novel. There are other infections that are really well characterized. There was a fair amount of literature that came out with Ebola when we had higher cases of Ebola that these people were really sick for a long time. They didn't have Ebola anymore, but what happened to their immune system and what happened to various end organs really impacted their long-term survival. So when I interact with patient advocacy groups or patients themselves that are extremely frustrated that we haven't figured this out yet, I say, you're absolutely right. We need to be doing more as best we can. But, oh, by the way, this has been happening forever and we could never figure it out at all. The one benefit that we have in the setting of long COVID is that for this other stuff I've already shown you is that no one in the world had it before, and then everyone in the world had it before. And the prevalence is so high that I actually have a chance of identifying people that probably have post-SARS-CoV-2 specific phenomena that gives us a chance to study. And that is really the unique opportunity that COVID presents, because I don't really care about SARS-CoV-2 at all. Like, if we cured it and it went away, that'd be fine with me, because this still happens, but this is a nice opportunity to actually have some idea what might be going on in the machinery, if you will, to lead to these persistent symptoms. I had a fancy picture, I guess I took that out, but there's a few buckets that generally fit for post-acute syndromes. And this is pathogen non-specific. So exercise intolerance, flu-like symptoms, neurologic or specifically neurocognitive impairments, or rheumatologic manifestations. And there's different infections, different courses that make some of these more likely. An enormous component to this is how severe the original illness was. But that's not the only explanation. Thinking about long COVID, it's really not as easy as it should be, even with all the things that are set up to its advantage. There is not a test. So there's no one that I can say for sure does have long COVID. Similarly, there's almost no one that has anything wrong with them that I can't say for sure that they don't have long COVID. So we're always kind of stuck. This has led to enormous frustrations, again, with our patient advocacy groups, because anytime we try to define things, we end up leaving people out, which is an intent to enrich what we're studying, but not to try to ignore other people. But again, you can imagine the frustration of having your world change and having people ignore you. So it's this very difficult situation. This is not a singular disease. There are a whole bunch of diseases that, one, are comparable to each other, and two, overlap. And no one says that you can only have one manifestation. So you can have some exercise intolerance, and you can have some flu-like symptoms, and you can have some fatigue. And so you might have 3 manifestations of long COVID, whereas someone else has 1, and one is not better or worse, it's just different. And carving those out into buckets makes it enormously difficult. And this has all muddied up the literature because everyone's capture of long COVID and who they're studying is not uniform for one disease. It's one syndrome that is kind of muckety mucked together. And again, it's worth emphasizing that I can explain this a lot, and that still doesn't help the patient that's sitting next to me. And again, they're justified in feeling that way, but this is not a new problem, and it's extraordinarily complicated. So it's not meant to like pacify, but it is just to acknowledge where we are and what the challenges are. So this, I've updated this slide because this is a relatively new thing, came out end of last year. This is now what has been broadly accepted as the definition. This satisfies patient advocacy groups. It's really important for a definition, so for insurance payments and disability considerations. But this makes some intuitive sense, but it also kind of says nothing. I won't comment on, like, they spent years coming up with this. And to their credit, they did an amazing job. And like, again, there's all these patient advocates that weighed in and really thought about the language, and every word in here has been validated and considered. And it's right, but it means nothing. And that's the challenge of this. But this is helpful because they do at least set a time point. There, you can find a report that says 93% of all people experience long COVID, but they cut off their days at like 10 days after infection. And you can find other people that say like no one gets long COVID, but you look at their cohort and their definitions and it doesn't make any sense. So it's really the prevalence for early SARS-CoV-2 anyways is right around 15, 20%. What it is going forward in the context of reinfection, it's lower. I'll let you know that. I'm working on a manuscript with Recover right now looking at reinfection. It's lower, but it's definitely not zero. This is just to demonstrate it's a hot mess. The most common ones are up here, but it's a very, very diverse disease. And again, it's not a disease. It's like saying cancer is a single disease. It's hundreds. Well, I'm talking to pathologists, but hundreds and hundreds of different diseases that we lump together that are really distinct in what's going wrong and how they manifest. It leads to a lot of overlapping symptoms, but the cause and therefore the treatments are going to be distinct in many of these situations. And without having those details, it makes it tough to design an effective clinical trial or tough to group into buckets for research analysis to quantify a cause and identify the biomarker. Because really what you're looking for is biomarkers of 2, 3, 10, 15 different things, and then seeing who has evidence of multiple of them. And that's hard to do without enormous numbers and really intensive testing. Although we're getting there. All right, so I gave you some buckets before of post-acute sequelae. This is a bit more specific to long COVID. These are pretty self-explanatory, and they're very much not limited to this, but most symptoms kind of land in these buckets. What doesn't seem to hold water is that these buckets don't really seem to correlate to specific etiologies, at least not yet. There's obviously some things that stratify to one or the other, but they're not unique to any one specific manifestation. So getting back to our data, or sorry, one more slide before that. So this is intended to emphasize one of the points I made earlier, is that the one thing that sticks out more than anything else is that if you were to want to get long COVID, the single best thing you could do is get the worst case of severe acute COVID that you could. I would counter that by saying how much of that is COVID versus how much of that is post-critical care sequelae. There is not a test, nor is there a difference, I suspect, for a lot of our patients that had profound illness. Jumping back, we enrolled, one of the last people we enrolled on the ACT study and we gave her placebo, it turns out, because we unblinded her. She was still in the ICU, and we gave her remdesivir after the DSMB canceled remdesivir study. So that was in the first week of May. She left the hospital, and there was a newspaper article on it. I think it was December or maybe November of that year. And while that's a bit of an outlier, it certainly wasn't a singular case of that. Her likelihood of going back and doing whatever it was 3 days before she met me is 0. And some of that is SARS-CoV-2 specific, but a lot of that is end organ damage. And so thinking about how to navigate long COVID is that some of this is tissue injury. Some of that tissue injury is almost certainly reversible, and yet some of that most certainly is not. And then discriminating those things is actually pretty important. to think about treatments and management, because if it is irreversible, like there's still clinical management strategies we can do. But right now we still have a lot of patients walking around hoping and being told by at least some people that this will all get better if they take their vitamins or they do this other stuff. And desperate people make less good decisions sometimes, so it makes sense. But these are static damage diseases. There's also things that are going on in long COVID or post-acute COVID, where the virus triggers it, but then it starts a process that then does not resolve. And these are obviously ripe for therapeutic intervention. The trick here is trying to discriminate the two, and that we identifying what's going on and then how we would be able to interrupt this process. This is one of the best papers, I think, that came out of COVID. They looked at people post-acute COVID and then went in and did gut biopsies and showed that they had longitudinal shedding and they could actually find virus in the gut. And they were looking not 30 days, but they were going out like 180 or so days, and really did a nice job of showing some of this persistence of antigen. So at a minimum, there is virus that exists persistently after infection that does not resolve entirely early. What they don't do is correlate this directly with long COVID, although there are these broad associations. This is a little snippet of other data that's come out. There's been a lot of work on this, but some different studies that have shown, I don't know where this paper is. I saw this data at least 2 years ago, but this is not officially reviewed and published yet, apparently, but they did a couple different cohorts. Recover was one of them, doing PCR and finding evidence of spike protein persisting in people that have long COVID. So if you do really high sensitive, clean assays, you can find spike that looks real. Here's the little tidbit that doesn't get emphasized as much. You can also find a fair amount of spike protein in people that are symptomatically fine. So just the presence of lingering antigen or spike isn't enough to tip you over into symptomatic disease, which is totally not surprising in context and yet infuriating at the same time. This is another study looking at evidence of ongoing antigen and persistent metabolic activation in sites that appear to have some reservoir. This is a really cool study. This is a UCSD group, and they did kind of the opposite of what we did. I collected a crap load of people and collected as many samples as we could, but we ended up being very cross-sectional because we had bits of data from a whole different group. They ended up getting 240 or so, but they just wore those folks out. And I mean that in credit to them. They sampled very intensively. They surveyed very intensively very early on. And they've published some really, really nice papers based upon a much smaller number. And one of the few things that I'm going to take away from COVID more than any other is just thinking about that and cohort building and how the ability to characterize disease is important, but being able to do mechanistic work really relies on kind of aligning your cohort the best way possible. Those were intentional decisions that we made. Like I think we talked about these on some of the Zoom calls for enterprise and how best to kind of align our efforts. But it's been interesting to watch how they've done this. And they have some really fancy toys over there that they've used successfully as well. So in relation to this persistence, what about giving antiviral? And long before this ever made it to a study platform, you could certainly find a chiropractor that would prescribe you your vitamin C and an antiviral. So this was being done, and there were anecdotal reports that some people felt amazing afterwards, others that less so. I don't have a punchline yet. We are a site for this. The last study visit was very early this year. We just closed data a few weeks back, so we really should get first-line data quite soon to see if this made an impact. I kind of jumped ahead of my own slides there. So it directly gets at this theory that is very evidence-based, that there is some degree of persistence. A couple problems or limitations with this is that I just told you this is 15 different diseases. This study tried, so it enrolled people in buckets. There were 3 different symptomatic buckets you could go into, but I still don't know what was causing them to land in that bucket. So I don't have a way of really enriching for persistence. There's some post hoc analysis that's going to go back and look at PCR and run the exact same platform that showed it was performing well to look at PCR for spike. But again, even that's still kind of messy too. But I am highly skeptical that the top line data will be positive, but there is hope that there's going to be some subgroups that pop out that give us something to look at. The other thing that I think is really important to think about is that let's say you do in fact have virus, and I'm being intentionally vague on what that virus is, and then you give an antiviral. Well, my literal job and what I'm going to go back in the hospital to do in here in 20 minutes is to give antivirals in the right setting. But I don't like magically eliminate virus by giving antiviral. I deflect kinetics down. Like that's really all I can achieve. In a reservoir situation, like the kinetics are functionally zero anyways. So it's not like my Paxlovid or my remdesivir or anything else is going to immediately go in and shut that down, because that requires viral replication. I don't have antivirals that kick things out. I have antivirals that shut down replication. So whether or not this strategy will make a meaningful impact for a large portion or even a reliable portion of people that have persistent COVID symptoms is less clear. It is urgently needed to be done. It's a tool that we have. So let's use our hammer and hit a nail, but I'm not convinced it's going to be a meaningful impact. There are other studies that are using antibody, which is a bit more compelling to me when you think about the mechanisms of antibody and ADCC and other factors to be able to go in and identify reservoir and perhaps eliminate that more effectively. Those things haven't happened on a big scale like this. They're happening more in kind of mechanistic-based smaller studies. I'm gonna do like a little quick tour through other mechanisms, or at least proposed mechanisms of long COVID. Something that has been shown pretty consistently now is that with acute COVID, if you go looking for them, you will find other stuff. This is not terribly surprising to me. You turn on the immune system, and most of the pathology of COVID appears to be immune activation. Turns out you can activate these other viruses that have been hanging out at baseline. What is interesting is that there does seem to be an association of greater recovery of CMV, greater recovery of EBV, and long COVID. What I am more skeptical on is, does that mean that they're causing anything, or is that just an output of the disease itself? But it's certainly something that's going on. And what that does suggest is that there's probably other immune cells that are getting activated, and there's probably antibodies that are going around, and that does kind of increase the likelihood of developing some autoimmune profile or inflammatory profile that could be going on. I don't think we're going to get a slam dunk answer from this work, but I do think it kind of demonstrates the dynamic detente we have with viruses that are chronic and how the immune system turns on and turns back off. Persistent thrombotic endotheliitis. We knew actually the lady that I told you about that stayed in the hospital for 10 months. She was having respiratory challenges. She actually looked better for a very slight moment, then had a massive intracranial hemorrhage. And unfortunately, that wasn't tremendously uncommon. We had people that would clot, and we would have people that bled. Turns out management of more severe patients benefits from some anticoagulation, but it's kind of this delicate dance in people that are really sick. There is ever increasing evidence that certainly during acute disease, and then certainly at least some of the time persisting after acute disease, that platelets are really angry and sticky, and that complement may be exacerbating this, and that there's a whole bunch of recruitment that may go on, probably in some of these antigen reservoirs, if not viral reservoirs, that ultimately leads to some actual clot in regular vessels, but a fair amount of clot in very, very small vessels, which fits with some of these symptoms like neuropathy, some vision changes, some other neurologic manifestations. So definitely something that's happening. There are some of these platforms that are moving forward for intervention, because we don't fully understand exactly what's activating what. A lot of the interventions are kind of like anticoagulation cocktails to see if that can resolve disease. Going back to some of the concerns, I don't know how much of this is ongoing and active and how prevalent that is versus how much of it was a manifestation in early disease. And as we approach baseline, that whatever damage is there and microvascular damage is not something that's going to readily go away. But this is definitely an area of very active consideration. And I think this is enormously important to figure out as best we can, because this happens all the time in generalized sepsis in specific pathogen interactions. So the more we can understand about how to deal with this, the better off we'll be. But I am a little skeptical on our ability to reverse a lot of it as we have people that are manifesting with persistent symptoms. A lot of discussion about this. There are some really cool papers that show generation of autoantibodies after COVID. What is interesting, and again, not that surprising, is that there's a lot of autoantibodies in people that end up not having long COVID, but did have COVID. So how much of this is spurious noise from a really cranked on immune system versus how much is pathologic? I am sure it is both. And I am sure I can't tell which is which quite yet. It is possible we end up identifying some clonal populations. There's some really big studies looking at this across Recover, and we're in a better position there to tie back biologic manifestations and potential biomarkers back to clinical manifestations because you have this kind of longitudinal exposure to them. I'm 100% sure some of this is going on, and yet I'm 100% sure it's probably less than it looks like on first pass, but it's an enormously important area to explore, and there is some cool data on it. One more, which I think is extremely compelling and really unites a lot of these others, is that there is clear evidence of mitochondrial dysfunction. I am not a mitochondrial guy by trade, but I think I'm going to have to be just looking at some of the manifestations of this acutely with COVID. And then also this really seems to fit those buckets that are not COVID specific. There's a bunch of different mechanisms for this. Some of it's reversible, some of it is not. There's some really cool data showing that for people that have post-exertional malaise, meaning they exercise, they get short of breath, and then they can't recover, and then they actually get worse later on, that they cannot onboard oxygen, they cannot burn energy, and they actually like have necrosis of their muscles. So there's fancy electron microscopy showing like tissue damage from exercise. So going back to chronic fatigue, where for 50 years we told people, usually young-ish women that were perfectly fine, you're crazy, go exercise. And we're now showing a bit more evidence that is exactly wrong. The question is, what the hell do we actually do? Because I don't have a way of recovering these mitochondria right now. But I think we're getting much closer to being able to quantify and characterize what's present, which then should help us inform how we got there, which then maybe will go us, if not able to dramatically reverse those that have manifestations, be thoughtful about how we got there and what we might be able to do differently. You can envision a role where if you knew exactly at someone risk that you could give them oxidative stress interventions and acetylcysteine or something, but until we know more about it, we're kind of stumbling around in the dark. All right, I'm going to kind of do one more brief whirlwind tour of things that are going on both with me, but more broadly in the field. And then if you guys have questions, I'll be happy to entertain them. So as mentioned, because of this huge cohort we had, and we had pretty good data, we were able to show like, hey, we're following thousands of people. You should have us participate in your study. And oh, by the way, 40 to 45% of the people that we've enrolled are African-American. And really, those two things were enough for us to end up becoming a site for Recover. I had been doing this work, and then given the high visibility nature of it, we kind of had a shotgun marriage of me, Emily Levitan, School of Public Health, and then my boss at the time, some lady named Marazzo. And so we took on Recover and have been navigating this. So we're one of the 3 or 4 largest sites for this study where we do adult cohort. There is a representation of the pregnancy cohort here. We do not have the pediatric cohort here. And then Dr. Benson jumped on the grenade of the autopsy cohort, which I think is super interesting as well. And we were already talking about ways that we can try to link these a bit more intentionally. This is a prospective cohort. And in the field, but particularly in the media, there's been a lot of trash talk about Recover lighting money on fire and not delivering the goods, which I get because you have thousands of patients that are miserable and frustrated and aren't giving treatments. And yet it is a prospective study for a very, very complicated disease. And the way prospective studies work is you put a lot of front end in it, and then it starts manifesting later. I get why that is not warmly received, but it is kind of a function of the agreement that we had in the beginning. There is things coming out of this. And again, we have a really cool trajectory paper that New England Journal actually gave favorable reviews to, but then squashed. But it's going to find a home very soon, and we'll be able to tell you about what the trajectory looks like of long COVID symptoms on Recover. I'm writing and need to be submitting like soon a paper on what happens for people that do and don't have long COVID with their symptoms when they get reinfected. And then this paper was both really well received and it's been cited a whole bunch, and yet people freaking hate it, which is defining what is long COVID. It's really intended to be a research definition of these people with these constellation of symptoms likely have long COVID. These people may or may not. That was interpreted by many in the patient advocate group of you're real long COVID and you are not real long COVID, which I totally see why that would piss people off, but it wasn't said that way. It just got captured in the media, and unfortunately it kind of ran out of control on it. We've updated this paper now and have refined the definition, adding in more data, and it turns out it didn't really change it a whole lot. And we have stopped calling it a definition because a little PTSD, and it's now a research index, which just kind of suggests we give you a number, and that suggests how likely it is you meet a definition of long COVID, and then how likely that is that you actually have a SARS-CoV-2 manifestation. But this is enormously important and really hard to do outside of a prospective group. So this can inform who does and doesn't go on a clinical trial and how you'd characterize them. Congress gave another not small pile of money to long COVID in the pre-days. I have no idea what's going to happen in the post-days. And it was specifically for treating long COVID platforms. That money exists and it's going to be wielded. I have a meeting coming up this week. We had a bunch of meetings last fall, and I kind of suspect all those meetings are irrelevant. So I don't know what we're going to get, but we have a lot of money to spend on doing some hypothesis-driven studies is the intent. The idea that we had before the world got caught on fire was to do some more intensive hypothesis-driven studies. So instead of trying to come up with a therapeutic, throwing it out the wall and enrolling hundreds of people, let's do something with an intervention, but maybe not, and maybe more research based on a few dozen people and really sample them intensely so we can look at these mechanisms, start trying to stratifying what actually got us here. And I think this platform is well positioned to do that. They had said out loud that it was going to kind of lean into the AIDS clinical trial group, which is something that we've done a lot of as well. But now all AIDS clinical trial group is kind of on hold right now because that grant is on pause. And so I don't know. I'm sure it's going to be a very illuminating meeting on Tuesday, but we will see. There are clinical trials that have been running under the Recover umbrella. Vital is one. We have a exercise intervention that I'm also doing here. And then there are a couple, 3 others that are going. 2 of these have enrolled, 2 more are close, and 1 of them not so close. So I'm going to run through some research stories, and I'll go relatively quick. But if you guys have questions, I'm happy to train them. I've talked to you over and over again that we can't tell who the hell has what going on. So we had the idea, one, that we have a whole lot of people at UAB that have been referred for pulmonary long COVID. Let's try to figure out who has what going on. Can we stratify them? And it'd be really nice if we use some biometric analysis that was readily available that would actually tell us what's going on. And also, the way our pulmonary clinic was working for long COVID referrals is that before they would even look at you, they would refer you for spirometry. So you would go downstairs, you'd blow into the machine, and you'd come upstairs and they'd look at you. So we started looking at, well, maybe that will tell us some different groups. Here's the cohort. I'm going to just plow through it, though. You're welcome to find more. I'm happy to talk about it. This is a very large table that says across our different groups, they look like the same type of people. And I'm going to skip the rest of that. I forgot this was animated. I apologize. This is a table saying the more sick you were, the more jacked up your PFTs were, which is not terribly surprising going back to some of the conversations we've had, but it's a very quantitative way of assessing that. We started kind of lumping them into buckets. So the things that we were noticing that seemed to correlate with how symptomatic and how likely it was that you weren't feeling well was how much diffusion impairment you had. And if I can ever get through my animations to the next slide, I will show you what that looks like. So this is the different groups, and this is showing over time how these performed. I'm going to spare you going through it, just say that there were a hell of a lot of PFTs done. And if it makes you feel any better, most of these PFTs were done and written down on paper and scanned in. And so I spent an enormous amount of my life pulling these PFTs out and also capturing all their granular data so we could fill out all those tables I just showed you. This is another paper that actually sat at New England Journal. It was very positively reviewed, and they voted it up and down, and it ended up just kind of missing their cutoff of what was going to go in. And then we chased journals before we ended up landing in Insight, but it's been cited a bunch of times, and I think it's a really helpful way of thinking about it. The point that I think is worth pointing out here is that we have different manifestations of disease. Those that have restriction and those that have diffusion impairment, but really those that have diffusion and restriction impairment, they don't get better. And that's really the point here. You see a lot of folks that will get better, but the ones that are sick, they are locked in here. So there's 2 things that we really think that's worth taking away from that. Is one, we can identify those people, even if they feel poorly, that based upon what your lungs look like, you are likely to feel better quickly. And there's others that we really need to think about what's going on here and be thinking about interventions. The pattern to my pulmonary colleagues, I don't want to state that this is my area of expertise, looks a lot like IPF and fibrotic changes, which based upon some other stuff I'm not showing here, there is an enormous amount of recruitment of neutrophils into the people that do poorly. And there's all sorts of tissue remodeling that happens. And what appears to be happening, and there's some trends in this, that this is an ongoing process where they continue to have tissue remodeling and fibrinolysis after their acute episode. So to us, this is one of the first ways of really digging into long COVID and differentiating. These people all report dyspnea, and they all have different degrees of impact on their life. But when we look at their PFTs, I can immediately put them in buckets of who's going to get better, for almost for sure, who is very unlikely to get better, and those that are kind of in the middle. All right, I will admit, I stole this from my MD PhD student, and I had no idea how much he had animated it. This was just kind of us looking at it, and the takeaway is not too surprising, but even more so than severity of disease, what really, really drove this was your degree of oxygen exposure. One of the things that we hypothesized in this is how much that might be actual oxygen being venated on high oxygen and high PEEP versus it was just a whole lot of disease. And it's harder for us to say, but I think that's one of the areas of hypothesis that we want to look at. And I'm recruiting people that have other respiratory illnesses to see if we can replicate this pattern and get a handle on that. It's really hard to control for, but turns out bad disease is bad. Also, there's some patterns on imaging, and we had pictures for most of these patients because they all got CT'd early and then many of them got CT'd late. So we spent a lot of time quantifying these and putting them into buckets, but it's really the PFTs that drove the story. This is just to make the point that we know you have these restrictive patterns and we know you're unlikely to get better. Like, well, it probably makes, those are places where using some of these really fancy but extraordinarily expensive medicines would make sense for a clinical trial platform. But without these type of data, you don't know who is and isn't likely to respond to it. We have follow-up to this study where we were awarded one of these Recover associated grants. So we've bronked a couple dozen people and we have a whole bunch of samples that we're in the process of getting ready to run. So I'm not sharing much data on this because my postdoc is slugging away at trying to spend a lot of our money to get these data put together. Another story that this is actually technically through the NOCI as opposed to the ROA, but it was, again, early money that was thrown for hypothesis-driven work. And here the question was looking at adiposity, obesity, and diabetes as a contributor to manifestations of long COVID. The very brief takeaway on this is that even in the PFT study, diabetes pops out as a risk. We published multiple papers on bacterial co-infections. Diabetes pops out as a risk. Everything about risk for having more severe COVID tends to drift back towards diabetes. There's all sorts of reasons for that because it's multifactorial. They're more likely to be overweight. They're more likely to be out of shape. But there seems to be something about that insulin resistance and hyperglycemia that associates with disease. And we hypothesize that there may be something going on in the adipose tissue itself and or the metabolic derangements of diabetes that leads to ongoing immune activation, which that's not a new concept that diabetes is associated with inflammation. So we're trying to explore into that. Of all those people that we either came to UAB for COVID or that I enrolled onto COVID, we have a couple hundred people that we've done a bunch of sample collection on. We ran a whole bunch of flow and all of the cytokines and all of the fancy B cell lineages to really get a really comprehensive picture. It's amazing how little there is from that systemic assessment. Overall, we spent a lot of money to show that they're really, really similar, whether they're fat or not, or whether they have long COVID or not. But when we start, I'm gonna skip this. When we start going in the fat, there are very clearly differences. There's a lot of inflammation in those that have long COVID and those that are obese versus those that don't. And it's interesting is that there seems to be some bleed over signal where they're different in their blood on the metabolic level, but then we start seeing some of the immune activation in the fat. This data isn't quite ready for prime time yet. So if you guys invite me back, hopefully we'll be able to tell you a cool story in a year or so. Given my background, one of the questions I've had since the very beginning is, do you have manifestations of long COVID that can come from a bunch of different buckets and a bunch of different mechanisms? Well, my HIV population has been shown to have a higher burden of long COVID. And two, the nature of chronic HIV when you're treated is that you still have a reservoir. The reservoir still leaks, which causes persistent T cell exhaustion and persistent monocyte activation. And to me, that seems like, well, that should really skew what types of long COVID would manifest. So we're in the process right now of replicating some of these adiposity tissues or studies in HIV populations to see, is the pattern the same? Is it exacerbated? Does it wash out because HIV just overruns any signal that we'd have for SARS-CoV-2? But one of my students is fully in the weeds on this. One of the things that's kind of interesting is that a lot of the symptoms are very similar. We see a lot of oral complaints in HIV, to the point where we're actually going to start doing some sampling up here and trying to figure out if this is real or not. I'm still skeptical because this is the joy of doing human work, because the mice don't do this. But a lot of my humans, and particularly my HIV humans, there's a lot of meth that happened during COVID. And we're still recovering from how many people started using meth. So some of this, I think, is being conflated by that, but we've started running analyses, and the oral manifestations post-COVID still seem to be showing up. So again, more on that later. This is my last slide. Talk to you all about this. Like, there's some really cool science. We have a much better understanding of what's not going on, what is going on, and yet for the great majority of people that I get referred to, and I don't generally see these patients because I live in HIV land clinically as an outpatient, but I work with a lot of the providers that do. We still don't have very much to offer. We have some symptomatic treatment. I feel like my neurocognitive colleagues do a really good job of helping give coping skills to some of the neurocognitive impairment. There are some people that seem to benefit from anti-inflammatories, long-acting steroids on the respiratory side, but clearly some that don't. And it remains enormously frustrating for a not small group of patients. I do think we're going to keep making meaningful progress. And I think there's going to be some pretty extraordinary science that comes out of this long term, such that in the future, I might actually be able to deal with someone either on the front end when they have severe influenza and abort whatever processes might be happening, or have a much better idea of how I could intervene after the fact and reduce their symptom burden. But unfortunately, we are not fully there yet. This slide should be a lot longer. I just haven't updated enough. And so there's a bunch of people that really, there's a ton of work that's going on to make all these things happen. So this is a snippet of that. And that's what I have. So be happy to hear whatever questions you might have. Oh, Zdenek. What's up?
Is it face?
You know what it is.
And amazing body of work that you have done. It's really impressive. It's amazing. I guess all of us in the HIV field, we are really affected by what was happening in the HIV field in the late 1990s after we have implemented the highly active antiretroviral therapy. There was a discussion that went for about 5-10 years. We were discussing whether the virus is actually actively replicating. With a consensus, yes, the virus is hidden in the DNA, latent, but is it actually actively replicating in people who are adhering to the hard therapy? And it turned out it was.
Yes, yes, it is.
And
Not much.
How much?
Not much, but it definitely turns over.
And that was actually associated with the viral escape from immune control and with the persistent activation.
Yeah, it's all in the lymph nodes, it seems like.
But I remember all of these papers arguing against and for and against the persistence of the virus based on PCR. Many people arguing it's just the remnant of the virus, which is not functional. I see exactly the same thing happening in SARS-CoV-2. In my opinion, it's really, if you see RNA of the virus, it means the virus is replicating. Otherwise, the RNA is degraded relatively quickly and removed from the system. The other thing is it was relatively easy with HIV because we could look in CD4 T cells in the blood, while in SARS-CoV-2 we don't have a defined reservoir.
And what's clearly part of the fun and mess of SARS-CoV-2 is it relies on ACE2. So it goes all over the place.
Exactly.
But it doesn't go all over the place the same in different people. So some people have tropism, or it's upper airways. Some people tend to get lower airway, but we have people with kidneys, we have people with fat cells. Like, it's the compartmentalization of it isn't as uniform as you would expect it to be, just because of the nature of the virus interacting with the co-receptor. And that's complicated further by the strains, because all the variants happens through spike, and that almost inevitably skews those kind of subtle interactions. Although it is amazing how little signal there is for strains. Like, everything we've done, we always account for a strain. We've never seen a phenotype that really specifically is strain specific, whether it's manifestations, severity. There are some viral kinetics that show that some of the later strains had better kinetics, and yet there's this already conclusion in the literature that later strains are less severe. And I'm convinced that's bull, and that it's the patchwork of immunity that's present that makes it less severe, because no one can show us a model where they can show less pathology from later strains and early strains. If anything, I suspect that they're more virulent because the kinetics are more aggressive. It's just that it doesn't manifest that way in practice.
Absolutely, I agree on the last point. And I was just coming back to that. Also, the virus might actually change. There might be spikes in different tissues occurring in the same individual.
Yeah, at least in immunosuppressed, like the places we've seen variants are people that do have this persistent replication. Some of these have been captured in real time. Like there was a person infected in England that had demonstrated remdesivir resistance and demonstrated shifts in spike because they were clearly replicating for something like 6 weeks or something, and they got therapy for much of that. So that, I mean, the immune suppressed population is always the canary in the coal mine for what's happening in a subgroup of people that have normal immune systems. But
coming back to the point that, I believe you mentioned the same thing. I personally believe that the number of people with persistent SARS-CoV-2 infection is severely underestimated because we don't have proper methods to test it. That's one thing. Second thing, as you also mentioned, treating people with Paxlovid for this relatively short period of time.
Yep.
I believe it was 25 days or something.
Yeah, which is a long course, relatively speaking.
It is not going to eliminate the virus, right? So
Yep.
right after the virus will spike back. So these studies will, as you mentioned, will probably not be complete.
Yeah, I think there's an opportunity to do some subgroup analysis to see if there was any shift in symptoms, but then I think linking this to more immune active drugs as opposed to just using a brake pedal with an antiviral. I think you're going to have to go find the antigen and facilitate immune clearance. And I'm sure this is one of the questions we've had and we've never had really targeted yet, is that there should be variants at the T cell and B cell level that influences the efficiency of clearance on the front end, the deflection of progression, and that should directly correlate at a clonal level to those that are more or less at risk for long COVID. And that work just hasn't been there yet. And it's an enormous undertaking because it means epitope-specific level and activation-specific patterns of specific clones, but there should be something going on at the very acute phase that it's not random of who does and doesn't get it. There's all these other layers that conflate it, right? Your underlying cardiopulmonary disease, the severity of illness, how maybe even your inoculum, but there's something that's happening at a T and B cell clonal level that's influencing that. Yeah.
I don't know if I missed your point. What is your opinion about complement dysregulation as well as pulmonary conditions, long COVID?
Not an expert. I do have a paper sitting on my desk to do as soon as I get off service. That's a review of characterizing that. There's clearly patterns that there's changes. There are therapeutics that in small groups have shown some impact. I am not good enough to walk through which factors seem to be most driving what, but there's all sorts of descriptions on which things get wacky and which types of people and which therapeutics may provide some benefit. So it's very, very clearly an aspect of acute disease. How much of that is influenced longer term? I think it's probably going to show up in the thrombophlebitis aspect of it, if anywhere. But it's definitely something that is on the radar and still being sorted out.
Thank Dr. Erdmann again for your presentation. Great, thank you very much.
Yeah.
A little over 30 on this one.